always, it's a privilege to have you with us. Today's topic is home health, opportunity for consolidation. Leading the discussion will be John Vandermosten, a manager with Coker's Financial Advisory and Alignment Services, and Yang Zhang, a senior manager who is also with Financial Advisory and Alignment Services with Coker. Immediately following today's presentation, we'll have question and answer period. Feel free to submit your questions in the area provided in the GoToMeeting dashboard, and we will address each one individually. The participant phone line will be muted for the duration of today's presentation, and the materials will be emailed you along with an audio playback shortly after the conclusion of the session. I'm now going to hand it off to John, who will begin the discussion.
All right, thank you, Charlie, and thank you, everyone, for joining us this afternoon. We'll start with just a quick look at Coker Group. We're founded in 1987, and our FAS team performs over 100 engagements per year. As Charlie just mentioned, John Vandermosten and myself and Yang will be presenting home health today. And let's quickly go over the agenda of what we plan to cover. We'll start out with an overview, and then we'll move on to the current regulatory and reimbursement trends. And then we'll look at some of the positive trends in the industry that will lead to consolidation. And then Yang will continue with a discussion of the valuation considerations in the group. And then finally, we'll open up the call for Q&A. We start with the question, what is home health? And it can be answered in a few ways, but basically it's medical care provided in a patient's home. It can include therapy, wound care, prescription management, and also rehabilitation. Currently, this benefit is provided generally following a period of hospitalization. And Medicare has several rules that they have in terms of who can receive home health care, and they must be homebound, need intermittent skilled nursing, and also be under the care of a physician. And I also included Medicare's definition of what home health care is in the second bullet point. Continuing on, home health services are predominantly provided by Medicare, and there are 6 disciplines that are offered, and they range from skilled nursing to home health aid services. What's not included in home health are generally activities of daily living. Those aren't covered, and that would be things like meals or homemaker services or other care that individuals need that's not medical in nature. Referrals for home health come from a variety of sources, include primary physicians and nurses, discharge staff after a period in the hospital, and then also assisted living facilities. Home health, as you can see from the chart here, is a much lower cost of care, and on this chart we show the daily cost of care for 3 different types. Home health at first, and it's a couple $100s per day. Skilled nursing is a little bit more expensive at about $400, and then hospital care is just about $2,000 a day. Home health is important because it can save money. One of the biggest ways it can do this is through reducing rehospitalizations. A study using Medicare data found that the program spent about $17 billion annually on rehospitalizations. And a lot of these, 3/4, according to another study, found that they were potentially avoidable. So home health can play a pretty big role in reducing readmissions, and there are other studies which show the effectiveness of home health in doing this. And there are a couple of ways that I listed here how it can do that. But basically, home health can prevent readmissions by providing someone who can help the patient understand what instructions the physician has given them, and also help them do it if they can't do it personally. Finally, there was an Avalier Health study, which was pretty important in terms of looking at home health and some of the benefits that it provides in terms of reducing hospitalization rates. And basically what this study did is it looked at 3 different conditions: diabetes, COPD, and congestive heart failure, and looked at Medicare patients who either went to home health or some other kind of post-acute care, and looked at the costs and readmissions for those 2 different groups. And it found that spending was lower for those who used home health than in the other groups. And also individuals who used home health were less likely to be re-hospitalized than patients who used other acute care services such as skilled nursing. On the next slide, I discuss a little bit of home health history. I think it's important to understand where we've been to kind of understand where we are now. For over a century previously, most of these services were provided by religious and charitable organizations. However, in 1965, with the Medicare Act, the government took over the benefit and covered post-acute and chronic care. It was a very popular benefit, and hospitals liked it because it allowed them to reduce length of stay. So due to a relaxation of rules in the 1980s and the 1990s, the benefit grew substantially. In 1997, the Balanced Budget Act came out, and it recognized that there were some concerns about perhaps some spending that shouldn't have happened in the space, and they capped payments to home health agencies, and they replaced the cost-based reimbursement system with a prospective payment system. And this was generally in response to lax oversight and distorted incentives. In 2000, a flat sum was provided for home health, with something around $2,200, which is a big improvement over previous reimbursement rates, and that led to a substantial increase in the number of home health agencies that were providing services, but it also led to some activities that were probably not justified. A lot of smaller agencies added patients that weren't really there, and services were provided that weren't really necessary. So in 2010, this was really recognized in a Wall Street Journal article that pointed out one of the largest home health companies in the states there was evidence that showed that they were probably increasing the number of visits to increase their reimbursement. That led Congress to have some investigations and kind of created an environment where it was felt that more regulation and more monitoring was needed, which kind of brings us to the burdensome administrative environment we're in today. On the next slide, I just wanted to illustrate the trend in home health spending. I previously mentioned the Balanced Budget Act of '97, and you can see the dramatic decline there from approximately $14 billion annually spent to just about $8 billion. It was a big decline. A number of agencies went out of but you'll see from 2000 on that there's been a steady increase. And even though in recent years we've seen net cuts to home health, just because of the increase in patients covered, overall the expenditures in home health have increased. So because of a lot of the excesses that have gone on, there have been some challenges that the industry has faced. One of these reimbursement cuts, and the other increased administrative burdens. And I show right here just some of the major issues that they've been facing in those two areas. So in terms of the challenges, reimbursement cuts, as I mentioned before, the big cut was in 1997, which set limits on Medicare spending and refocused home health to post-acute care. They really narrowed the amount of services that were offered in home health. But then again, as we came a little bit later into 2000, the system changed again, and it became a little more attractive, and it grew. Right now, we are in an environment where there are several adjustments that are made every year to an episode of care. The three main ones that historically have been used are the market basket adjustment. And basically what this does is it's generally been a positive inflationary adjustment. However, it's been offset by the Affordable Health Care Act adjustment, which over the last couple of years has been 1% per year reduction, and then also a case mix change, which adjusts for code creep and upcoding. Rebasing has been the big concern over the last several years. That also was a mandate by the ACA, and it required that current costs be examined, the number of visits per episode be researched and to come up with a more representative reimbursement for the industry. So in last fall, finally, CMS completed their study and determined that they would cut rates by 3.5%, which was the maximum that was allowed. And the 3.5% cut is going to be phased in over a 4-year period, 3.5% per year for a total of 14%. And we'll see the last of those cuts in 2017. And the 3.5% cut was based on 2010 levels. Sometimes you'll see a little bit different number today just because of it was set on the 2010 level rather than the 2014 level, which is what's relevant for us going forward. There were some criticisms of what some saw as an indiscriminate cut to reimbursement here. The rates didn't consider capital needs, and they also didn't take into account all the additional administrative burdens that have come into play recently with the ACA and other mandates that have come out. Additionally, the rebasing cut even more the number of codes that could be provided for, narrowing the number of visits and other services that can be provided. Finally, the sequestration. This was something that was applicable to all government spending. For Medicare in particular, it was a 2% cut. So this was on top of all of the other reductions that I previously mentioned. So moving on to some of the administrative burdens that the industry has to take on. Face-to-face, this was a very concerning issue for the industry because it required the referring physician to do a lot of extra work. First of all, they'd have to meet the patient in person for each episode of care. And while that might sound relatively easy, recall that the requirement by Medicare is that the patients be homebound. So this made it very difficult for a lot of the patients to actually come into the office and visit the physician. The second requirement that made things difficult was a narrative justification for why the patient was receiving home health care. A lot of individuals felt that this was already being met, the justification for the home health was already being met, so it just required the physician to do something extra that they hadn't done before. So the problem was that a lot of physicians didn't understand that it was necessary, and also it just was an extra burden that when they had hundreds of patients, it was easy for them to not do. So without the physicians making this narrative addition, the home health companies could not get reimbursement for the services they provided. In response to the face-to-face requirement, the NAHC, or the National Association for Home Care and Hospice, they filed a lawsuit challenging the requirements. And partially probably in response to that, although we're not sure, CMS actually proposed eliminating some of the narrative requirements that were the biggest problem that the NAHC and other organizations felt were burdening referring physicians. Some additional administrative requirements that also have been layered on, and you know, again, a lot of these were in response to what was summarized in that Wall Street Journal article that found, you know, some questionable behavior by some of the home health companies. But one of these is PICOS registration for referring physicians, and basically this is PICOS is a database for physicians who have to register with CMS, and it's supposed to be effective this month. It had been pushed back several times, but I believe it's actually going into effect right now. Additionally, quality requirements. Quality and reporting it is very important. It's something that's required across the industry, but it requires extra paperwork, extra manpower, extra effort, and there is no extra reimbursement to cover this requirement. Starting in 2015, actually there is no reduction of payments. There's actually no payments for any provider, any home health provider that doesn't provide its quality data to CMS. And then an additional burden, ICD-10. This has been delayed many, many times as well. Right now, it is expected to go into place in October 2015, and it will incur some training and IT costs, which again aren't really covered by the reimbursement that's received. So recently, just before the 4th of July, CMS came out with their 2015 home health proposal. As I previously mentioned, a big positive in that was the elimination of the narrative requirement. They also announced their first take on what 2015 rates will be. Overall, after all the adjustments fell out, overall expenditures are expected to be down 0.3% or $58 million. So this is a relatively positive outcome. In the past, total reimbursement has come down 1 to 2 percentage points after all the adjustments. So this is actually somewhat of a positive. There are some other proposals that CMS also made in terms of OASIS submissions and recertification requirements. So after covering some of the burdens and reimbursement cuts that the industry has faced, there are also some opportunities out there, and I guess I would categorize them into a couple of areas. One is the bundling, accountable care, Medicare Advantage area, where the management of healthcare services is pushed down to the local level, and a provider or group of providers receives a set sum to best manage the healthcare of their population. Additionally, collaboration in M&A, and also a big positive for the industry is the growth in the addressable population. So we'll start out with bundling. I think we all understand what bundling is. One of the concerns about bundling is generally it lowers reimbursement overall. However, I think it can help home health. And Medicare has one example of this called the Bundled Payments for Care Improvement Program. And basically, it'll pay a lump sum to cover hospitalization and post-acute care. And what it'll allow is when a patient is ready to be moved out of the hospital, but they're not quite ready to be on their own yet, they can be put in the home health. And this, I think, will, looking back on what I discussed earlier in terms of the efficacy of home health, how it has reduced readmissions, and it's allowed patients to do a lot better after they leave the hospital, I think this is recognized at a local level, and I think that it'll lead to improved demand for home health services. And I point out the reason why right here. Bundling allows for local management of care and costs. And the concern over home health and a lot of the pushback from Congress and other organizations is that it's kind of out of control. It's not done in the hospital. It's done at an off-site location, and sometimes questionable visits happen. And I think that if it's managed locally, then there'll be less concern, and it really can play a big part in terms of reducing hospital length of stay and improving readmission rates. Accountable care organizations. This is another area very similar to bundling, where a group of physicians receive a set payment for a population, and they can locally manage the use of the healthcare dollars to best take care of the patient. Medicare Advantage. This is a managed care product that actually could actually provide a nice improvement in terms of reimbursement, because they can charge a copay. Currently, original Medicare is not able to charge a copay for home health services, which limits the reimbursement that a provider can receive. So as with the other items that I mentioned here, Medicare Advantage can provide for more efficient population management. Finally, collaboration in M&A. A lot of the points that I mentioned earlier in terms of the additional administrative burden, it's very difficult for smaller operators to put into place all of the requirements that are necessary in terms of getting referring physicians signed up in PICOS, and also making sure that they code everything correctly and submit quality information as it's required. So what this really is doing is forcing a lot of the smaller players to consolidate with larger, more technologically advanced players who can, make the expenditures for IT upgrades and leverage that across a larger organization. There are a number of examples here of recent transactions or potential transactions. One of those is Kindred and Gentiva. Gentiva is the #2 largest home health company in the U.S., and they tried to get together, but Gentiva did not want to. But I think Kindred recognizes the benefit that can be out there with bundling and some of these other population management pushes that are out there to combine their skilled nursing with Gentiva's home health and put the patient in the kind of care that's most appropriate towards them. You can see other examples: SCL Health Systems, Pioneer Community Hospital, Cigna and Health Systems, and even Humana in the managed care space. They're one of the biggest players in Medicare Advantage. They acquired a few home health, American Elder Care in 2013, and Senior Bridge in 2011. So there are some transactions already happening which recognize some of these points that I've brought up. Okay, the next slide is just an example of the population breakdown in the United States, and we can see the baby boom generation there right now, from where it starts to bulge in the top part. That's going to be flowing through and start becoming the Medicare population, which is the user of these services. So there's a strong tailwind that's coming in terms of demand, and with a lot of the pressures that we're seeing in terms of budgetary constraints, there's going to be a need for lower cost health care. And if it's possible to move a patient from skilled nursing to home health, or from the hospital home to home health, and it's an appropriate place for care for them, then I think it's something that's going to have to be done. There just is not the funding to do it in another way. Just going over some of the statistics relating to the last slide. Currently, 43 million persons over 65, and we expect that to grow to 72 million by 2030. Put another way, about 13% of the population today is over 65, and that's expected to increase to 20% by 2030. And I make the point here that most of the individuals who are in home health or receive home health care are over 85 years of age. I mean, you can see that here in this one point. I bring up about over 85 group spending almost 10 times more than those under 65. So in summary of these slides, with demand increasing, budgetary pressures increasing, lower cost and effective home health can fill a valuable role by reducing hospital stays and lowering readmissions. At this point, I'm going to pass the presentation on to Yang, who's going to discuss some of the valuation considerations.
Thank you, John. John has just given us a very good overview of home health industry segment and its opportunities. As he mentioned, due to the payment changes, hospitals are incentivized to align with home health agencies and make them a part of the hospital's delivery system and to capture the resources necessary for the ACOs. So and these alignments can be structured via either contract, joint venture, or acquisition. So to facilitate these transactions, there's a need to know how much the home health agency is worth. So as many of you in the audience probably know, that home health is one of the designated health services covered by Stark Law. So therefore, to align with or to acquire a home health company, typically the transaction has to be structured on a fair market value basis. And for compliance purposes, the appraisal has to be done by a qualified third party. So I'm going to talk about the key factors that should be taken into account when valuing home health entities. On the next slide, before we get into valuation details, let's take a look at the fair market value definition. This is important because it sets the foundation of the valuation analysis. So on top of the page, we provide the fair market value definition in the IRS Revenue Ruling 5960. This is what is used in most business valuations of all industries. This definition emphasizes the concept of any willing buyer and any willing seller. So basically what it says is that the fair market value represents the value for any potential buyer of the asset that's on the market. The fair market value is different from what we call investment value or strategic value, which really is reflective of the value for a specific buyer. So for example, when a home health agency is acquired by a tax-exempt hospital and become a part of the hospital, it will be able to take the advantage of the hospital's tax-exempt status. But however, to calculate the fair market value of the home health agency for transaction purposes, its earnings must be tax affected because the tax-exempt status will only be available after it becomes owned by the hospital. So valuing the company based on the pre-tax cash flow, which again would only be available after it becomes a part of the hospital, will result in investment value, which is not a purpose of a fair market value appraisal. So but as we talk about the health services, transactions have to be compliant with Stark Law and any kickback statute. So in healthcare, the fair market value definition is more limited, and because under the Stark Law, the price of compensation cannot take into account the value associated with referrals. So it is very important to understand the unique nature of the healthcare compliance environment and to select an appraiser that understands the healthcare industry. In the next few slides, we'll briefly cover the key valuation considerations of home health companies. So, and I would say the valuation approaches used to value home health companies are not anything different from when we value other healthcare entities. But the appraiser needs to have extensive industry knowledge and to be able to apply those knowledge into the valuation of the home health companies. So first of all, let's talk about the income approach. The income approach values a company based on the present value of its expected future cash flows. I would say this is the most widely used and also the preferred approach to value healthcare entities, including home health. Under the income approach, there's a methodology called DCF, or discounted cash flow methodology. It involves a forecast of a company's earnings and free cash flows over a multi-year period, and then the forecasted cash flows are then discounted back to present value using an appropriate discount rate. And the value of the business is basically the sum of the discounted cash flows. In our practice, we typically do 5-year forecasts, but sometimes it takes longer for a company to stabilize its earnings, for example, startup companies. And so in those cases, we will extend the pro forma for a few more years. I must say that the income approach, because it relies on the forecast of future cash flows, it's typically not used to value business that are not profitable. And so for those businesses, the asset-based approach or the market approach will be more appropriate, and we will discuss those a little bit later. Let's go back to the DCF model we just talked about. Its advantage is that it allows us to quantify the various key factors affecting the value of a business. And we're able to project each future year's revenue, expenses, working capital, capital expenditure, etc. So because of this ability, we normally believe that the DCF model, if it's applied appropriately, can produce the most accurate value. But of course, the pro forma forecast is a key component of the DCF analysis. And if you're not able to project future earnings and cash flows on a reasonable basis, the value would be skewed. So it's very important that the appraiser perform a detailed due diligence review of the company before the actual valuation analysis. So here we try to summarize some key factors that must be taken into account when we develop the pro forma forecast. First of all, reimbursement outlook. I think this is very important, but also in the meantime, very challenging aspect of the pro forma analysis. As we know, home health business relies on third-party reimbursement, and a large portion of their revenue comes from Medicare. I would say roughly 70 to 80% of the revenue comes from Medicare. So as John has mentioned, the home health segment has been negatively affected by Medicare reimbursement cuts, and this will continue to be a threat for those businesses. And John has also mentioned several factors influencing the Medicare rate adjustment, which includes market basket adjustments, productivity adjustment, and rebasing. Although we are relatively clear about the reduction due to the rebasing, but the extent of impact from other factors is still unclear in the next 5 years. So typically until the final Medicare rates are published by CMS, really nobody knows for sure how it is going to play out in the future in terms of reimbursement. So it is very important that the appraiser understands the payment system in effect and the proposed changes that's out there, and adjust the pro forma accordingly. A lot of times the appraiser needs to draw on his or her industry expertise to determine how likely the proposed changes would actually take place, and then apply the assumptions into the valuation calculations. I would say this is not a easy task. In our practice, we try to estimate the future changes in reimbursement based on the proposed changes, the historical trends, and sometimes we'll also get opinions from industry experts. But quite honestly, there's no way to know for sure how Medicare will adjust its payment rates. So sometimes, depending on the perceived likelihood of the rate adjustment, we'll also consider adjusting the discount rate, the WAC, to account for the uncertainty. Also understanding the referral source is also very important. When you look at home health and valuing those services, you will need to understand where the patients are coming from. If the company is heavily reliant on a single or a small number of referral sources, you need to think about the potential impact of the transaction and how the transaction will impact the future referral pattern and the stability of the business after the company is being sold to the buyer. For example, if the home health business is a part of a group and the majority of its business comes from the group's internal referral, whether they can continue the same level of volume post-transaction, sometimes that need to be carefully reviewed. And another example is the whenever the home health agency does have multiple resources or referrals, for example, independent medical groups and PCP doctors, you also need to understand the consolidation activities in the market. So if those referring doctors in practice are being acquired or being employed by a hospital who has its own home health division, then the future volume of the home health company that you're looking at could likely reduce. So you need to take that into consideration as well. Another thing that needs to be reviewed is payer mix. As we have already discussed, most home health agencies rely on reimbursement from a variety of payers. And those payers include Medicare, Medicaid, commercial insurance, and patient private pay. And so to value home health businesses, the appraiser needs to understand the payer mix and to, based on this, to evaluate the company's risk profile. Let me give you some example. For a home health agency that has a high concentration of commercial insurance payments, the appraiser needs to look at the local economy and the employment data to understand, whether there's a possibility that those patients might lose their commercial insurance coverage. And for a business that has a good amount of patient self-pay, you will also need to review the income data of the service area. And of course, because Medicare payments represent the majority of the revenue for home health companies, it's always important to understand the age profile and the population of the service area. And as far as expenses, owner compensation will be one of the key items for review. For a privately owned small home health care provider, the owner compensation in the historical financial statement does not necessarily reflect their market value rate. So during the valuation process, it's frequently adjusted as a part of what we call a normalization process. And also John mentioned that additional expenses that could be incurred due to the administrative requirements that's currently in place for home health agencies. For example, the additional manpower that could be needed to meet the qualified requirements and the IT and training costs as a result of the implementation of the ICD-10 system. And these costs will not be reflected in the historical financial statement, but when you perform the forecast, you need to give it some thought. One thing that's also challenging is when the home health business now you're looking at is a part of a large group or a hospital system. In those cases, the home health agency you're looking at does not have its separate income statement, and oftentimes there is not a balance sheet at all. So, in those cases, we'll have to rely on the divisional income statement that's prepared by the company, in which we hope that can capture the revenue and expenses associated with the home health business. But when this is the case, the appraiser must also carefully review the revenue and expenses allocation assumptions and make sure that appropriate allocation has been performed. And if not, you have to make your own adjustment. For example, when the home health business is a part of a large group, it could be managed by a centralized business office. And depending on how the group sets its accounting reporting system, the business office expenses and the corporate overheads may not be reflected in the divisional income statement that you're provided with. Or if it does, there's a possibility that the allocated cost may not be quite at the market value levels. So, centralized business office can sometimes realize some economies of scale. And, for example, accounting fees could be lower than the cost that could be incurred when, the business goes out and gets its own service. So, the appraiser needs to understand if the report expenses are reflective of market norms and if the allocated expenses will continue to incur in the hands of a potential buyer. On the next slide, we'll talk about the market approach. The market approach is another widely used approach to value home health businesses. It includes two methodologies, including the guideline public company method. This one values a company based on the stock price of comparable public companies. And another method under the market approach is the merger and acquisition method. And this values a business using the pricing multiples from what we call comparable transactions. The most frequently used pricing multiple is the EBITDA multiple. Revenue multiple is also used, but it's more frequently to use companies that do not have positive EBITDA. And on this slide, we provide a summary of the major home health care public companies and their key stats. We pulled these figures from Capital IQ, which is another database that we use to value companies. As you can see from the table, these public companies operate a number of business segments, but this could be a problem when we value a small home health agency. As you probably know, 50% of home health agency have revenue that's lower than $3 million. So these key differences, you have to look at if the companies are comparable in terms of size and the service line. It's often difficult to find a public company that's truly comparable to the company that you're looking at. And also because of the size differences, it could also result in key differences in terms of capital structure, access to capital, diversity, and depth of management. So because of the key differences, we typically do not see the guideline public company being used to determine the value of the small home health agency. Let's go back to the previous slide. The table on the bottom gives a summary of the home health transaction that's took place since 2010, according to press stats. As you can see, there are a total of 22 transactions in this database, and of those, the median reported MUIC to sales ratio is 0.4 times, and the median market value of U.S. capital to EBITDA ratio is 4.8 times. So there are also a lot of issues with the merger and acquisition methodology, mostly related to the transaction data that's available. In most cases, the reported transactions very general. The information available typically include, just the business description, the company's last 12 months revenue, and EBITDA. But it does not tell you, key things like the market conditions and growth perspective of the company, which is more important in determining the value of a business. So without this key information, it's very difficult to determine whether those transactions are truly comparable to the company that you're looking at. And also, when you look at the transactions, you'll also notice that a lot of buyers are financial investors who are not subject to fair market value requirements. So in those cases, the pricing multiples could be skewed because the pricing could include what we call synergistic value that will have to be removed under the fair market value standard. So because of these issues we have discussed, in most cases, the market approach is not used as the primary approach to determine the business value. But that does not mean that the market approach is not very important. We have to look into the market data and make sure that the value is within market norms. And in our practice, we frequently use the market approach as a more like a secondary methodology or a sanity check to evaluate the overall reasonableness of the conclusions from the income approach. Let's turn the slide to the asset-based approach. The asset-based approach is also called the cost approach. It values the individual assets comprising the business. For example, the tangible assets, supply inventories, working capital, and intangible assets such as assembled and trained workforce. And then these individual values are consolidated to get to the overall business value. The asset-based approach is most frequently used to value businesses that have significant tangible assets and not a good amount of intangible assets, such as service companies. So, the reason behind that is it's very difficult to determine the value of intangible assets strictly based on the cost of recreating them. So because of this, the asset-based approach is not typically used as the primary approach to value home health businesses. So I'm not going to dig into details of this approach, but whenever the business is not profitable, the asset-based approach would be a very valid approach to determine the minimal value or the score of the value of the business. So that's an overview of the business consideration for a home health agency. So I'm going to turn it over to John, who is going to lead the Q&A section.
All right. Thank you, Young. That was a great overview of the valuation approaches that we use. Right now, we're going to move into the Q&A section, and I think we do have a couple questions from our attendees. So at this point, I'll take a look at the first one and I'll read it out. The first question, one of our major hospitals sold their home health citing significant annual losses. How can that be with a billed referral source? Seems like they should do the best even with reduced reimbursement. Well, I guess, some of the things you need to think about is maybe the cost structure was already too high, because of some of the burdens that have come on, the administrative burdens and the revenue reduction. So what likely happened is that the cost structure was probably a little bit higher in that circumstance, and when the additional reductions came along and additional burdens came along, it just was no longer viable. I guess going forward, we see things as being a little bit more positive. When there is consolidation, generally there's an ability to cut costs. Perhaps the hospital didn't have the scale to really leverage some of the things that are out there. So I guess that's how I'd respond to that. I think things will be better going forward. And also, is the hospital taking part in ACO? Are they receiving bundled payments? Because I think that's really where home health can be used. If the hospital just has a home health agency and they're still under the original Medicare rules of satisfying these requirements, and it only comes after a period in the hospital, it's not really taking advantage of some of the the local management that can take advantage of home health and move patients out of the hospital and into a lower cost home health environment. So I guess that's how I'd respond without knowing a little bit more about the details on that. But again, the reductions in reimbursements that we've seen are going to eliminate some of the home health companies out there that have the highest cost structures. There's another question. Yang, would you like to see if there's a question that you're interested in taking?
Yeah, sure. There's a question coming regarding the valuation approach. The question is there one valuation approach that's head and shoulder above the rest, or do you recommend reviewing valuation methodology? My answer would be, the income approach would be the preferred approach to value healthcare entities in general, and this includes the home health. The reason behind that is that there's several key things that's affecting this industry, and for example, the reimbursement cuts, but in the meantime, the patient volume is increasing. So the income approach allows you to take all those factors into consideration, and this is more beneficial than the other two approaches, which is the market approach and the asset-based approach. The market approach, as I said, it's always difficult to find truly comparable transactions. So, because of those reimbursement adjustments, the historical transactions may not necessarily reflect the current reimbursement environment. So, in those cases, we do not consider the historical transactions being comparable to what we're looking at. And again, the asset approach, because of limitations, it's typically relied upon when only when the company is not profitable. So again, the income approach will be our preferred approach, and this is also I believe the position that most healthcare operator firms take. John, you want to see if there's any more questions?
Yes, I think there is another question. I'll read it, and Yang and I can probably answer this one. One of our listeners asked if there are any advantages to using a certified valuation expert versus one that's not certified. And also they are asking if investigation thereafter is initiated by an outside entity, such as CMS or the OIG. Yang, do you want to take that? I mean, I guess I can start by saying that the ASA designation, which Yang has earned, represents a certain level of experience and education that's required by the designation. and it shows that that individual has experience.
Yeah,
and, we think it's important. Young, do you want to talk about that a little bit more?
Yeah, sure. Yes, we always recommend that you use a certified appraiser when you value home health agencies, because the healthcare companies is highly regulated, and you have to make sure that the fair market value standard is applied with in your transactions. And in addition to having a certified appraiser, we recommend that you use appraiser that has very specific industry knowledge. And we COCR review a lot of appraisal reports from other firms, including CPA firms and other small companies. That sometimes we found that if the appraiser does not have good knowledge of healthcare, it's always going to be problematic. So yes, we do recommend you use a certified appraiser. The ASA designation will be a very good demonstration of the appraiser's qualification. And again, we would recommend that you use a healthcare appraiser.
Thank you, Yang. And we have another question. What impact has Obamacare had on the industry? We discussed a little bit of that in the presentation. First, we had the mandatory 1% reduction over the last several years in terms of reimbursement. Also, the rebasing, which required that CMS take a look at the costs that were being expended in the episodes that were being applied, and came up with a recommendation in terms of how much should be reimbursed, and they came up with the 3.5% reduction over the next 4 years. So that would be the major one. Additional rules that are positives for the industry from Obamacare would be the bundling that we discussed, the ACOs, generally where healthcare is managed locally and there's a single payment that's made to treat a condition from beginning to the end and involves consolidated care. And I think that because home health has this low-cost position in the healthcare continuum, that in that situation it will do well. It looks like we have yet another question. How is bundling an opportunity, given that it usually leads to overall lower reimbursements? That is true. That the focus of bundling is to actually lower cost overall, and I think again that goes to our point that home health, in terms of reducing emissions and being a lower cost mode of care, can really help fit into the continuum of care, and dollars will shift away from hospitals and skilled nursing and into home health. Even though they may be lower overall, home health will be a relative winner in that circumstance. Let's see, we have another question asking about how much capital is needed to run a home health company. I was just reading about the breakdown between labor and capital in terms of Medicare reimbursement, and I think on average they find about 77% of the expenditure is towards labor, and the rest is toward administration and capital and whatnot. So it's a relatively small amount. Computers and IT systems are the major expenditures in the home health space. We have yet another question that's coming in droves right now. What are the margins in home health? The margins, they vary significantly. Some are negative, and some are in the mid-teens. Medicare actually has done a study looking at margins, and I think that they remove a lot of the costs that are in there that we would look at as appraisers, that they don't determine are directly attributable to home health, but they find margins in the mid-teens levels. Based on my experience, I've seen them in the high single-digit range, and we should expect them to decline a little bit after these additional rebasing takes effect. So they'll probably decline in the near future and probably be offset somewhat by some of the growth opportunities that I mentioned. It looks like at this time that there aren't any further questions. And I think that we would like to thank you for your time today.
Yeah, I'd like to thank John and Young for the presentation. Again, the slides to this presentation and the audio link will be emailed to all the attendees shortly. In the meantime, please check out our website at www.cokergroup.com for details on our next Coffee with Coker. Thanks, everyone. Have a great day.